So again, it's my pleasure tonight to welcome you to our foot and ankle pain, identifying the causes and finding the care webinar. And then again, it is my pleasure to introduce our speakers tonight. These folks have volunteered their time to put this together and to be here tonight to give this webinar, and we really can't thank them enough for the time and effort that they've put into this. So first tonight, we have Dr. Shari Moore, who graduated from Dr. William M. Scholl's College of Podiatric Medicine. She completed her residency at Hennepin County Medical Center in Minneapolis. She's a board-certified podiatric surgeon with 30 years of experience, and she has experience and interest in peripheral nerve surgery of the foot and ankle, elective reconstruction surgery of the foot and ankle, diabetic limb salvage, and sports medicine. She is affiliated with the University Hospital and Abbott Northwestern Hospital, and she is a member of the American College of Foot and Ankle Surgeons, Association of Extremity Nerve Surgeons, American Society of Peripheral Nerve, and the GNF. So we're very excited to have Dr. Moore with us tonight. Our second speaker will be Dr. Kevin Powers, who graduated from Indiana University in Bloomington and also graduated from the College of Podiatric Medicine and Surgery in Des Moines, Iowa. He's a board-certified foot surgeon with over 36 years of experience. He has received training in Boston and Philadelphia, as well as the Dellon Institute for Peripheral Nerve Surgery, advanced training in Baltimore, Maryland. And he's also taken advanced training at the Mayo Clinic School of Research. So thank you for being here with us, Dr. Powers. And then our third speaker is Dr. Kent DiNucci, who attended the Scholl College of Podiatric Medicine as well. He is board-certified foot surgeon with over 30 years of experience. Dr. DiNucci served in the U.S. Armed Forces and the Air Force, which we thank him for his service. He served a 3-year residency at the Swedish Hospital in Seattle, Washington. And he is affiliated with the OSSC Surgery Center, the CHI Health Creighton University Medical Center in Omaha, and the Methodist Hospital System, UNMC. So again, I can't thank our speakers enough for being here tonight. For the audience, I just wanted to let you know our speakers cannot provide specific diagnosis. This is for general information and to provide information and thoughts that you can take to your physician and have more informed conversations. So to that point, our goals are really helping you to understand the basic biology and function of peripheral nerves, identify and describe the anatomy and function of common nerves in the foot and ankle, to recognize common injuries that people often have in their foot and ankle, recognize any signs and symptoms associated with nerve injuries in the foot and ankle, and then also develop strategies for how to discuss the management of nerve injuries, as well as various approaches with your physician. So with that, it is my pleasure to turn it over to Dr. DiNucci.
Thank you, Steve. When we talk about the nervous system, we have two basic divisions where we have the central nervous system, and that's really your brain and spinal cord. And what we deal with a lot is what we're going to be talking about today is your peripheral nervous system. And that's really the wiring. And it's very similar to the wiring of a house. You have the wires going all in through into different rooms. They're held down to the walls or in the conduit. They are little things that bind them down and hold them down in places, and that's what we're going to find today that occurs in our body as well. And some of these little things can cause impingement or other problems. But this wiring can sometimes go bad, and we're going to talk about some of the different injuries. When we look at the the peripheral nerve components, the cross section of a nerve is very similar to what you would find in something like an underwater cable, and you can actually see that in this slide here, where you see some of the cross sections. But if you look at the actual nerve, you'll see tiny little blood vessels and little arteries and little veins. And those little things can be compressed very easily. And we'll talk about that later too. But you can imagine it's so small that it doesn't take much. That's why just crossing your legs for a short time can make a nerve go numb or shut it down for a little bit. And then, when you let the pressure up, you're okay. But if that pressure continues, you can have problems. You can see here the little fascicles and other things that we have to deal with if you have a surgical problem, how tiny that can be to try to repair these things. And so that can be an issue as well. So when we look at different types of nerve injuries, um, you know, their nerves can close to the surface. Those can more easily be cut or damaged. But some of the nerves, when they go through tight spaces, can also be insulted. There are really three major categories of nerve damage. Can either stretch it, you can cut it, or you can compress it. And we'll go through all of those with each of us in the different ways. Um, and um, and so you can see on this slide here where we have a lot of different nerves in the lower extremity that we have to be aware of, and all of the different wiring. In this slide, we have a lot of different branches coming down here, and this is why you really need an expert in nerves to start to diagnose these and discuss the different pathology that can come from a nerve injury, because there's so many of these little things, and you have to really be in tune to this in order to really diagnose these properly. And nerve injuries can come in all shapes and sizes, as we just talked about, and we're going to get a little bit more into depth with that. When a nerve is cut, it's actually, you can see that the brain is not going to get any signals. It's no different than a wire being cut in a house. You can flip the switch as many times as you want, and the light's not going to go on. And so if a nerve is damaged, everything beyond that, farther away from that nerve towards the spinal cord, is actually going to go numb. And or if there's motor function there, you're also going to lose muscle function too. And so most of the time that's a surgical issue where we need to go put that back together. But you can see that and that we do have many techniques now where that makes it easier to do that nowadays with some of the new techniques and really nice technology that gives us a much higher success rate than we ever have had in the past. So when a nerve is compressed, that's one of the ways, like we talked about, that where a nerve can be damaged. This is the picture of a carpal tunnel, and that's the most commonly recognized tunnel that people really look at. And you can see here on the picture on the right where the nerve is swollen. And we have nerves that just run through these tiny little tunnels. And a tunnel with no space, like it says here, it leads to compression. And so sometimes that comes from, repetitive injury, where you sit at a computer for a while and do some things like this. But if that can irritate the nerve, and sometimes it's because the tunnel itself can change. It can morph over time as we get older and we lose elasticity, and it can get tighter and tighter. And that can actually end up not giving as much. And so the nerve ended up getting more pressure placed on it. And so then it can't do its job. And like when we look at these cross sections of nerves, it just puts more pressure on a nerve, and you don't get those tiny little blood vessels coursing through, and they're not able to give nutrients to the nerve, and hence you get numbness and tingling and all these nerve symptoms we talk about. So stretching a nerve is also bad. A nerve can only stretch, between 4 and 6% before you start having some permanent nerve damage. And they don't like to stretch. They're flexible like a little piece of spaghetti, but they're very accurate in what they transmit, like a fiber optic cable. So it's no different than taking a piece of bubble gum and just pulling it, and it gets more and more narrow in the middle. And that's what happens to a nerve as well. And that can really cause a lot of havoc inside of a nerve. And many times a nerve will try to repair itself, but it can't. And it can't because of some of these areas of compression that are natural, these natural anatomic areas of narrowing that we've come to find in the lower extremity and upper extremity. And these little areas will be a relative constriction because of the damage or trauma that's occurred to the nerve just beyond it or around it. And so now you don't get the waste products out of the nerve, you don't get the nutrients back in. And so a stretched nerve can happen after an ankle sprain or ankle fracture. And sometimes, these things don't go away, even though the ligament damage or some of the actual bones are healed, but people still have these nerve symptoms like burning, tingling, numbness up and down their legs. And that can cause some real confusion with diagnosis if you're not in front of a nerve surgeon or a nerve specialist.
So I'm going to talk about nerve pathology in the forefoot, and we'll be taking our conversation from the toes back towards the ankle. The first thing we'll talk about is a Morton's neuroma. A lot of people are familiar with this. It's a very common injury to the forefoot. And basically what this is, it's a thickening of the small nerves on the bottom of the foot in the forefoot. It usually occurs between the third and fourth digits. The long bones of the foot are the metatarsal bones, and there's a ligament that runs between those metatarsal bones, and that nerve can get injured underneath that ligament. The symptoms of this are basically pain and tingling in the forefoot. People will often grab their whole forefoot because they can't really identify exactly where it is, but it's just this aching pain in the forefoot. It's more distinct in that it's not real reproducible. It'll come and go. It'll come and go with activities. It doesn't necessarily happen every step. And if the nerve is thick enough, you can actually develop what's called a Mulder's click, where you can actually feel that nerve rolling underneath the bottom of the foot. People will describe it like their socks are pulled up and then they can feel this clicking sensation. It's most commonly, as I said, between the third and fourth toes, but it can happen between any of those intermetatarsal spaces. It is more common between the third and fourth toes just because of the biomechanics or the way your foot functions. There's a little bit more laxity or rolling in that part of your foot. And anatomically, the nerve that goes between those two toes is just a little bit larger, so it's more prone to getting entrapped and injured. The causes of a Morton's neuroma. This is truly one of the pathologies of the foot that you can blame on a shoe. A high heel is classic for this. Your weight is pushed forward in the shoe, and then the shoe squeezes those bones together. And as you can imagine, what's depicted in that picture, that nerve will get squeezed between the bone and cause the inflammation and damage to the nerve. Trauma, a direct trauma, or trauma from a previous surgery in the area can cause some injuries to the nerve. The entrapment component, what we had talked about with the carpal tunnel, this is a tunnel in the forefoot. So the ligament is running between those two bones, and that nerve gets stuck as the toes are moving. You can picture the toes moving up and down. It's going to pull that nerve like a tether, and it bounces against the ligament and becomes damaged. As I had mentioned, the biomechanics of the foot will contribute to this. You see this most commonly with a flatter foot that's more flexible. You see it with repetitive motion. Up and down motions are real classic for this. So think of what you're doing when your foot's moving up and down, driving a car in traffic, walking up and down stairs, and then the high impact sports where you'll get pounding of your forefoot can cause this as well. Non-surgical treatment for a Morton's neuroma, the simplest thing to do is to look closely at your shoes and make some modifications. Patients will do better with a stiffer soled shoe. What that's doing is preventing that up and down motion of the toes, which are acting as a tether and pulling that nerve against the ligament. A wider shoe with a wider shoebox, so you're not getting that pinching of the metatarsal bones pushing on that nerve where it runs in between them. Ice, anti-inflammatory medications like ibuprofen, orthotics, which are customized arch supports that go in your shoes, are an option for treatment of this as well. That works by stabilizing that hypermobility in the foot where the foot's just moving with more laxity in the forefoot. It makes it so it doesn't spread out and takes away some of that strain on the nerve from the pressure when the foot moves. Metatarsal pads are just real simple pads that you can sit underneath the metatarsal bones in the foot. And it really acts to just kind of push up on the metatarsal bones and acts to spread those bones apart and take some of the pressure off of the nerve. Activity modifications, identifying what causes this and what's aggravating it and modifying those activities. Cortisone injection, I use it sparingly in my practice. And then the orthotics I already mentioned. Surgical treatment, the traditional treatment for a Morton's neuroma has been to do a nerve resection. It's called a traction neurectomy, where the nerve is removed from that inner space. The complications that can occur with that is that nerve wants to regenerate. What we've learned over the years is nerves are smart, and so they try and reform, and so you can get a newly formed bulb of nerve with that procedure. So a more emerging procedure is to do a decompression surgery, which is treating this as a true nerve entrapment, similar to the carpal tunnel that most people are familiar with. You can release that ligament that runs between those metatarsal bones, and by releasing that ligament, it gives the nerve space to move up and down and heal. Then next we'll move to the top of the foot. The first nerve that we'll talk about is the deep peroneal nerve. In the slide earlier with the nerves of the lower extremity, the sciatic nerve comes off from behind your hip. It runs down your leg. It divides into branches at your knee, and it divides into the deep fibular nerve at that level, which goes down your leg. It gives strength to the muscles that pull your foot up and down. And then it goes down into across the ankle where it runs under a ligament, and then it goes to the first web space between your first and second toes. So that nerve can get entrapped in two separate areas. It can get entrapped where it's crossing across the ankle, and then it can get entrapped also at the forefoot. Symptoms of this are just a generalized aching in the foot. It's kind of hard for patients to distinguish exactly where that aching is. They'll kind of grab their foot and say, it aches across the midfoot. And then often they'll get real distinct sharp pains going into the first and second toes. Causes of the deep peroneal nerve injury. This is a stretching or traction injury. You think of the activities that people are involved in that cause your foot to move down, which would put a strain on that nerve. So think of the dancing, the diving, the gymnasts where they're always pointing their toes, certain prayer positions where you're putting a stretch on that nerve. Compression can cause this. This is another injury that can be caused by a tight shoe, putting pressure in that area, tight bandages from prior surgeries, and then also pressure from the anatomy that's in the foot. If you think of your midfoot, it's analogous to your wrist with all the small bones where they meet up at your wrist. There's a similar area in your foot, and where this deep peroneal nerve crosses across that area of the small bones, you can have little arthritic spurs that will push on that nerve and cause some compression. Trauma, direct trauma from an injury, dropping things on your foot, that type of scenario, prior fractures, and then the repetitive motion, the up and down motions that I've already mentioned. The nerve can get entrapped at two separate areas. The first area is at the ligament where it crosses underneath the ankle. And then the second area is more in the midfoot where it crosses kind of where all those small bones are. It can be aggravated with chronic ankle instability. And again, also just the biomechanics that I had mentioned already. Conservative treatment for this injury, paying attention to those shoes and how you lace them, and different lacing techniques can help. Shoe modifications, ice, anti-inflammatory medications, physical therapy. They can do some deep tissue work on that nerve to try and get it moving again. Cortisone injections, again, can be used sparingly on this. And then the orthotics, again, to control that extra mobility in the foot and give it more stability to take some of the traction pressure off of that nerve. Surgical treatment is basically releasing that nerve. The nerve is running underneath the tunnel, and so this picture is depicting where it crosses at the ankle. There's a retinaculum, or a band of tissue that crosses the ankle, and it holds the tendons in place. That nerve runs underneath that ligament, so that can be released at that area. Sometimes that ligament is just extra thick and is putting extra pressure in the area. And then moving down into the forefoot, there is a muscle that goes and helps your big toe get pulled up, and that nerve can get entrapped under that muscle and can be released surgically at that level as well, period. And then, of course, removing any of the bone spurs that are contributing to it would be done at the same time. The other area on the top of the foot that you can get a similar nerve entrapment is the superficial peroneal nerve. This is a second branch that comes down from where that sciatic nerve divides at the knee, and this runs down the leg. It emerges from the deep tissues kind of at the bottom 1/3 of the leg, and then runs and kind of fans across the top of the foot, more like a broom. Symptoms of this are similar to what we find with the deep peroneal nerve entrapment. It's tingling, numbness, tightness, and burning on the top of the foot, and then sometimes going into the bottom outside part of the lower leg. Causes of the superficial peroneal nerve entrapment. Again, it's similar to the deep peroneal nerve. You see this with direct trauma, a side pressure to the lower part of the leg, prior ankle fractures or injuries to that area. And again, it's a traction injury, so it's correlated with ankle sprains. If you twist your ankle and it turns in, it can stretch that nerve. The nerve can get entrapped in the fascia, which is the band of tissue on the lower part of the leg. And sometimes that tissue is just thicker and it becomes entrapped in that area where it becomes more superficial or closer to the skin. The biomechanics or the function of the foot, you see this again with ankle instability. So orthotics can be helpful to stabilize that ankle so it's not twisting and putting that traction pressure on the nerve. And then compression. I think that's probably the most common way I see this nerve get injured. It becomes more superficial in the lower leg, about 10 centimeters above the ankle. And so that happens to be right where a lot of boot lines hit. Work boots. In my neck of the woods up in Minnesota, it's ski boots, military boots. And so it just happens to be right at that level. So non-surgical treatment, again, is similar to the deep peroneal nerve non-surgical treatment. You can modify your shoes, different lacing techniques if the pain is on the top of the foot, ice, anti-inflammatory medication, physical therapy. Therapists are trained in nerve gliding, which is getting that nerve to just move with specific exercises for the muscles in that area. Cortisone injections, and then again, the biomechanics can be addressed with orthotics. Surgical treatment is similar to the deep peroneal nerve. Basically, we're looking at finding the area where the nerve is entrapped and releasing the tight tissue in that area, whether it's at the leg, where it comes outside of that deeper compartment and through the fascia, or if it's in the forefoot and involved with the muscles, with the bone spurs in that tissue in that area. And this is just depicting a good picture of that nerve where it comes down through the outer part of the leg. And you can see where that nerve can be entrapped at the boot line is where it becomes more superficial.
Okay, I'll take over. Nerves on the bottom of the foot. Oh, go ahead, Shari. You're supposed to do this one.
Oh, okay. So we decided to just do a brief discussion on plantar fasciitis because it is probably the most common source of pain on the bottom of the foot, and it has a real distinct set of symptoms that usually resolve with some pretty simple treatment. And we put this in there just for background. The plantar fasciitis will show as pain with the first few steps of the day. It usually works its way out as the day goes on, and it usually resolves with some pretty simple treatment. If you have heel pain and it's not resolving or progressing, then you should consider that it might be a nerve issue. And now I'll turn it over to Dr. Powers.
Thank you, Dr. Moore. Yeah, plantar fasciitis is probably the most common condition foot specialists see. But if somebody has heel pain and it just doesn't get better and it lingers on for a few months and they've already had shoe inserts and maybe cortisone shots and change of shoes and physical therapy doesn't get any better, there's a high likelihood that it could be a pinched nerve, a nerve compression on the side of the heel. and that's called a medial calcaneal nerve. The word calcaneal means heel. And where the nerve comes down, it goes through a band of tissue and a muscle right on the side of the heel, and it can get compressed in that area. Squeezing the side of the heel causes intense pain. The plantar fascia is on the bottom of the foot, so if it hurts on the bottom of the foot when pressing, then that's a sign it's a plantar fasciitis. But if it hurts on the side of the heel bone, you probably have a pinched nerve in that area. The tarsal tunnel is a tunnel where the nerves go through, along with some blood vessels and some tendons. Similar to carpal tunnel in the hand and the wrist, tarsal tunnel is on the inside of the foot, on the side of the ankle. And that area can be compressed also. And that usually leads to symptoms on the bottom of the foot, where the bottom of the foot may burn or feel numb or ache or have shooting, tingling pains. And again, it could be previously diagnosed as plantar fasciitis that just doesn't get any better. Different foot structures could have cause this. Diabetes and thyroid disease definitely can cause a compression of the nerve behind the ankle, because that diabetes and thyroid disease causes that nerve to swell, and it goes through this swollen nerve through a tight tunnel, and that can cause it to become pinched or injured in that area. Injury to the ankle, like a broken ankle or a severe ankle sprain or a broken heel bone, can lead to this tarsal tunnel syndrome. And sometimes we see cysts or tumors grow inside the ankle, and we can sometimes palpate that and feel a bump there behind the ankle bone. Get an MRI, and it can show us if there's a tumor growing, and then that tumor is growing and putting pressure on the nerve, leading to tarsal tunnel syndrome symptoms. Okay, non-surgical treatment. I found that the best non-surgical treatment is wearing a better supportive shoe, and probably with an orthotic insert to fit inside the shoe. If somebody is on their feet a lot with their occupation or sports, sometimes the foot just needs to rest. There's an injury to the nerve, it just needs to rest. Anti-inflammatory medications are sometimes helpful. Steroid injection is a known treatment for this. I have not found that to be particularly curative. It may give some temporary benefit. When I have had to operate on people who had steroid injections at other places before they see me, I have seen injury to the nerve following steroid injections. So if a steroid injection is performed, it should probably be performed with an ultrasound to make sure the nerve's not injured. And the physical therapy, sometimes I found some benefits for it. If people get better with tarsal tunnel syndrome, it's going to be slow and gradual. There's not an instant cure. So have patience and go through the treatment plan as recommended by your doctor. All right, so if we do have to do surgery, we actually don't do anything to the nerve during the operation. The tissue, the tight fibrous, thick rubber band type tissue that's compressing the nerve is cut and divided and released. And that stops the pressure on the nerve. So this allows the nerve to heal itself. So after this type of surgery, we don't directly operate on the nerve, but we give the nerve an opportunity to heal itself, which can happen gradually over time. Occasionally, some patients have immediate relief of pain and the numbness on the bottom of their foot goes away. Other times it could take 3, 4, 5 months for slow, gradual improvement to occur as the nerve heals. All right, coming back to another nerve. There's another nerve that comes down the back of the leg, back of the calf muscle, and goes to the outside of the foot along the outside of the foot to the little toe. And this is a nerve that I see most commonly injured from a patient having surgery for different things, whether it's a repair of a torn tendon on the outside of the foot or the ankle, or repair of a broken heel bone, lengthening of the Achilles tendon. This nerve can become damaged or injured or stuck in scar tissue, become very painful. Conservative care, the same as the other things, sometimes a cortisone shot, some physical therapy, some anti-inflammatories, some deep tissue massage. But surgical treatment usually involves disconnecting the nerve from where it's injured, going into that traumatic area. Typically, that nerve would be stuck in a lot of scar tissue on the outside of the foot from previous injuries or from surgery. So we'll go up into the leg and disconnect that nerve that goes into the scar tissue, just like disconnecting an electrical wire that may be going into an area that's problematic. And that will leave that side of the foot permanently numb. But interestingly, over time, that zone of numbness kind of shrinks. And the patient gets used to that numbness. And my patients are always happy to trade the pain for numbness. It's a highly successful surgery. There's different techniques on how to do that. But that's usually what's performed when we see injuries to what's called the sural nerve, which goes to the outside of the foot. Kent, we'll turn this over to you, Dr. DiNucci.
Thank you. So what to do if you think you have a nerve injury in your foot or ankle, or even into the lower leg? So there are a lot of different types of specialists and doctors you can go to. And the first, a lot of people will go to their primary care doc because they treat most of what we're dealing with anyway. And primary care doctors are really good at knowing their locale, so to speak. They know a lot of people in the area, and they'll say, well, this is the rheumatologist I recommend, or this is the podiatrist I recommend. They know a lot more about this. This guy knows more about that. And so they sometimes know the ins and outs of the area and who might be specializing in nerves. And emergency room physicians also tend to see a lot of more traumatic injuries, obviously, and when a nerve is cut and when a nerve is damaged, but sometimes they get blamed for things that aren't their fault either. Like if somebody has a bad ankle sprain or an ankle fracture, that you have so much pain when you're there, they don't see the nerve issue at the time. And so after the fact, that nerve can start to swell up because of the traction injury, and it becomes compressed. And then they start having these symptoms after their ankle has been fixed or their ligament is better. And but a lot of times they will be able to recognize the cuts and the lacerations and things like this, and they can recognize that and then also send that on to the appropriate specialist. And if you have more of a chronic problem, if you've had this problem for a while and you really need to find somebody, then you're going to look for your specialist. So that's your peripheral nerve surgeon, and that can come in mainly these three specialists. Neurosurgeons can also be included in that in some respect, orthopedists, plastics, and podiatry. And so what you're going to find is that not all doctors deal with nerves. Not all doctors are specialists in nerve injuries. And these four groups or societies, so to speak, specialize in peripheral nerve injuries, repair of peripheral nerves, and how to recognize them, how to treat them. And even if they don't know, if that person goes there and knows, they'll usually know somebody who can at least address that problem too. Another specialist, maybe somewhere else in the country, maybe in another state, maybe right next door. But in these situations, when we're dealing with nerves, you need to go to the specialist who knows. And if that happens to be out of town, my recommendation is to go to that person. So what can you expect from your doctor when you have an exam, when you have a nerve injury? So history taking is very important. And so you, as the patient, you want to be as detailed as possible about what it feels like. Try to stay away from diagnosis when you're talking to a doctor. And so you want to get a history. You want to give that doctor a good history of what your symptoms are. And so most doctors, we're looking for objective evidence. But the problem is we're going to run a bunch of tests, nerve conduction studies. We're going to send you for an EMG, MRI, CTs, X-rays. You can't see pain. We can't see pain on any imaging studies. And so that makes it very difficult to get objective results. So that takes us back to a good history and our physical exam, where we actually touch and lightly brush or tap on a nerve. And we are correlating that nerve, the branch of that nerve, where your injury is, where you're feeling what might be damaged, and correlating that to where the damage might be, and then coming to a result. And we might know where the anatomic tunnels are that are well accepted. We might know some of this stuff, but sometimes the nerve isn't injured there. Sometimes it's in front of it, behind it. And sometimes there are anomalies, but that's what a nerve specialist is going to give you too. But it's the exam, it's that physical exam you're going to get that's really going to tell you the most. And what you'll find, next slide, sorry. But on the, it's that diagnosis of the peripheral nerve injury that's really difficult, because many doctors we're really kind of, we get these blinders on and we want some form of objective evidence. And so, if it's not seen on a test, it doesn't exist. Well, you need to trust yourself and say, I still have pain. And so if you, like I said earlier, if you need to travel to see other doctors, then that's what you need to do. Not every doctor is a specialist in nerves. And so you have to be patient. If a doctor does say, hey, look, they've identified the problem and they may educate you on the problem, but it might just take time for it to recover. Like Dr. Powers was saying, some of these things, even after you decompress the nerve and we're allowing the nerve to try to repair itself, it can take months, sometimes up to a year or more, for that nerve to just recover and keep growing and getting down to where it needs to be, whether it needs to reinnervate a muscle or whether it needs to get back to the skin area where it was damaged. But you also want to make sure that if your doctor doesn't really address your nerve injury, then, I guess I tell my patients, just smile and, let them know tell them the truth, be open with them. And if they're not addressing that, you can't force them to it. Maybe they just don't know much about nerves. Maybe they're not educated. Then you need to do your own research and try to go to one of these societies, these nerve societies, and find somebody who can help you then with that. And I can tell you, the earlier you get to that nerve, the better. The longer a nerve continues, like we talked about, the nerves swell up. And in some of these chronic metabolic problems, like in the diabetes and thyroid and some others, the nerves swell and they can cause more problems. But the earlier you get to a nerve, typically the better the outcome. And the treatment isn't always surgery, like you've heard Dr. Moore and Dr. Powers mention. There are other things we can do for nerves that aren't surgical, but the later the treatment as you go along, and somebody says, it's not that bad. It's not that bad yet. And, if it's a knee, we have one sitting on the shelf at the hospital, but if it's a nerve, you have to fix it, and so we can wait on that knee until it's that bad. But when it's a nerve, you want to fix it before it gets that bad, because then sometimes things don't restore themselves all the way. And like the bottom of this slide says, expectations are everything. And so if you have a problem that's been there for a long, long time, chances are you can, if you see a nerve specialist and we say we can help this, you might get better. Whether you're going to get to 100% or not, that's the big question, right? And most of the time people are going to improve, but I can tell you they don't always improve 100%, but they're a lot better than what they were. And a lot of that depends on how quickly you can get to the nerve or how badly it was damaged to begin with. There's a lot of factors that come into play with that. So here's the, this is the Global Nerve Foundation website, and the top of this where you can go right in here and find healthcare providers, and you can see different nerve specialists all over the world, on every continent. There's somebody in different specialties who can address these nerves. And so the reality is that if you run into somebody who doesn't know about it, you just keep going. You just keep looking, because there will be somebody who can identify your nerve problem. And there are a lot of people who really, really and truly are in this to help. And I can't tell you how tickled I get when somebody comes in and that much better. They're just so happy. I mean, they are kissing you and hugging you and sending you letters. I don't get that when I fix a bunion, but I get that when I fix somebody's nerves and they can sleep now and they don't have that chronic pain that just eats at them all day long. It's really rewarding. It really is. So if you do have surgery, if that is what you end up having, before surgery, discuss your medical history. A surgeon always needs to know all of your medical history. I recently had a patient who forgot that she'd had a kidney transplant. And so it had been 25 years before, and she didn't let me know that, she was on these meds. And she says, I just forgot to put all that down. It wasn't until we talked to her primary care doc that he reminded me of some of these things that were going on. So she had a nice chuckle out of that. But, the basic things, there are some medications we can give people to help calm those nerves down and that helps some of the postoperative pain as well after nerve surgery. And so you just want to make sure that you follow all the basic instructions. Every surgeon has different protocol as far as how they do it, but mainly, you don't eat after midnight. That's a basic thing. But during surgery, again, the protocol is different for different nerves, how you might be positioned on how to repair it. So local anesthesia with sedation is very common. That's the majority of the cases that I do. There are some cases where I need general anesthesia. And most of these cases are done outpatient. And I would say the majority of my cases, my patients are walking. Unless I have to make an incision on the bottom of their foot, they're usually walking after surgery. And I want that because they need to move. I want them moving after surgery. And that decreases scarring. But you can expect that the nerve you're going to have some pain and you're going to have swelling after any surgery, whether it's nerve surgery or any other surgery, that is. And so you're going to have sutures and you're going to have bandages and you want to leave them alone. You don't want to mess with them unless your doctor tells you, change this or, look at this. You may need a period of rest before you go back to activity. I have a common statement in my office. I tell people you can walk for your needs, not your wants. And so that helps them start to figure out how much they can do, but like I said, expectations are everything. And your surgeon should be able to give you some good expectations, and if your surgeon doesn't, then don't be afraid to ask. You should say, what's the success rate? How much of this is going to come back? How much do you think is going to improve? And I think that's a very legitimate question for a patient to ask a surgeon, and without any feelings of being threatened or anything else. You need to ask questions, and that I encourage all my patients to ask lots and lots of questions. More questions?
Yeah.
Perfect segue to the questions.
Yeah.
So I'm going to go ahead and stop the screen share. I see we have a hand raised. If you could please use the Q&A box for any questions, we'll take those there. And then I will start with the questions. One thing that came up multiple times as far as a possible non-surgical treatment was orthotics. So I was just asked, maybe Dr. Powers, I'll toss this to you to start, but where or how do patients or someone in pain, how do you go about finding proper orthotics, or is it just off the shelf? Should they find a foot and ankle specialist in order to really have special orthotics made? Like what's the best approach for orthotics?
We usually recommend patients try some inexpensive over-the-counter supports. There's plenty you can get on Amazon. And if they work, great. If they don't, then they should probably go to their local podiatrist, foot specialist, foot and ankle orthopedist to get some custom prescription orthotics made. And sometimes they're made out of plaster or foam box, or right now we just use a 3D computer scan of the foot that goes to the lab, and within 2 or 3 weeks prescription inserts are made. And these are custom made, like eyeglasses are prescription. So they're highly specific for the patient's foot structure, and usually one set will last many years. And if that stops their tarsal tunnel syndrome symptoms or their heel pain symptoms, or their ankle pain, then that's great.
I would like to add to that, if I may, there's two different types of orthotics, and a lot of people aren't aware of this. A traditional orthotic that most people purchase, the over-the-counter ones, and they work fine for basic biomechanical control, is an accommodative orthotic. It's truly an arch support. So if you do an over-the-counter arch support, that's pretty much what you're getting. There's a second type of orthotic that's more dynamic. It's a functional orthotic, and it's really more specific to the biomechanics of your foot. So it works by capturing the differences between your hind foot and your forefoot and balancing it out. So it allows normal motion but takes away the extra motion. And if you're not getting improvement with an off-the-shelf, over-the-counter type of orthotic, and you're an active person, it might be beneficial to seek out that type of an orthotic, which you'd most likely get from a foot and ankle specialist, as opposed to a limb and brace center, which also do wonderful work, but it's a specific difference between the type.
I'd like to add one more thing to that also.
Yeah.
I do all of that. I love orthotics for a treatment for that to correct the biomechanics, taking the pressure off of that tunnel a lot of times. Sometimes plantar fasciitis, like Dr. Powers mentioned, can irritate the medial calcaneal nerve and cause nerve problems secondarily. But there is a subgroup of people who have that plantar pain that have been diagnosed with plantar fasciitis or some of these others. And I really like giving them an orthotic because sometimes they can only tell. That's almost diagnostic for a nerve entrapment syndrome. If they put that orthotic under there and 10 minutes later, they can't tolerate it. Because I haven't found a way to predict who is going to be that person and who's not. But that in itself, I haven't found somebody who fits that category who doesn't have a nerve entrapment syndrome. And what you're basically, it's just common sense. You have a nerve that's really inflamed here, and you're riding an arch support right underneath there, and the nerve can't get out of the way. And so you're putting more pressure on that. And now the compression and they can't tolerate it. It feels great for about 10 minutes. The muscles, the ligaments, the bones feel great. And then all of a sudden the nerves are crushed and they start to have severe pain and they got to get it out. And those people will usually come in to my office with a grocery sack full of orthotics, and they've had 14 of them. And they'll say, I thought 14 was better than 13. But, I've had all these other shoes and I've had all this stuff. But those are the people who are also, they think they're crazy because they've been told that. And it's like, no, you're not. You just have a problem that we can't see on an objective test. And usually that person, that subtype has some form of nerve injury and they go unrecognized a lot of times. And I find, that's why I love orthotics for that. It's very diagnostic in that realm. And sometimes an off-the-shelf insert will help them. And sometimes a custom orthotic helps them even more. And sometimes it hurts them, but you won't know until you try it.
Great, thank you. All good answers. We have another question in the Q&A. So maybe we'll go kind of same order. I'll start with Dr. Powers and then, Dr. Moore, Dr. DiNucci, please feel free to jump in. But the question is referencing tarsal tunnel release and how much scarring should be expected. And it's a two-part. Then the other question is if you use a nerve wrap to protect the nerve while doing this procedure.
For tarsal tunnel surgery, the key to success is early range of motion. The old way of doing this was to put a patient in a cast, don't let them walk on it, which is the exact wrong thing to do. And some of the early papers written had a poor success after tarsal tunnel syndrome. That's because two things: the procedure wasn't performed properly, so there wasn't a full release going down into the arch area, and the patient was immobilized. So the key to success for tarsal tunnel surgery is early range of motion. So I'll have my patients, I don't want the foot to swell, so I'll just have them keep it elevated for a week, take it easy. They can walk around the house from room to room, go to the toilet, and that's about it for a week. Maybe use some ice on it. And then after 1 week, we take the bandage off and I have them start doing range of motion exercises of their ankle up and down 100 repetitions 3 times a day. And I'll have them do that for 2 months. So that's the key to the success of this procedure, and that minimizes the scar tissue. With regard to wraps, I don't routinely use a wrap for tarsal tunnel surgery unless it's a redo, because there's a lot of scar tissue and I have to go back in there again for a second time. Then I'll use a nerve wrap of some type. But I haven't had. I've been doing this for 14 years, and well over 100, maybe 200 of these tarsal tunnel surgeries, and I haven't had a problem with scar tissue adhesions if they start early range of motion. And I just have them do it themselves. They don't have to go to a professional physical therapist to have that done.
Excellent. Thanks, Dr. Powers. Yeah, go ahead, Dr. Moore.
I don't have a lot to add. I will say that some people just, in my experience, some people just do tend to form more scar tissue, and they usually know that when they come into you. They've had other surgeries where they've had scarring, and so some of it you just have to work with. I agree. I don't use wraps usually for the first surgery for tarsal tunnel, but revisions are usually being revised because there's scar tissue, and the purpose of a wrap, it's basically like it's a protective device to put around the nerve that creates an environment so the nerve doesn't re-scar down, and your body remodels that over 8 weeks. So the initial healing period where scar tissue is laid down is for 6 to 8 weeks. So if you have this wrap in place, it's really protecting that nerve during the majority of the scar formation. So it's really patient specific with the nerve wraps in my practice. But
Dr. DiNucci, anything to add?
Ditto. Everything they've said is right, spot on. I use wraps I will always use a wrap on a revision, because you'll have less just natural fat or adipose around the soft tissue area. You're going to have more scar tissue just inherently. And the best thing I can tell you is, like Dr. Powers said, just be compliant and do what you're asked to do. I can tell you most of my patients do well as long as they just do the protocol. Don't go looking for a used car the same day of surgery on your way home. Don't go through, IKEA or Costco because you're numb and it feels good. But, these are things that have happened, even though they're instructed not to. But they feel so good. The burning is gone, doc. The tingling and numbness feels so much better. And they're just so excited to get back to life. I can't blame them on one hand, but just do the protocol for that first few weeks until that skin is healed. And that's really what you want. You want that skin to get healed first. And once the skin is healed, then you can go to town on doing more activity. But that's the primary healing that you want. Otherwise, you have to get the deep healing from the bottom. And that's what you don't want.
mm-hmm.
Excellent. Well, we are coming up to our 1 hour. So I just wanted to take a moment, thank our speakers again. Really appreciate you all sharing your time, your expertise, answering some of our questions. So thank you so much. For the attendees, like I said, this will be posted on our YouTube channel and on our website. We'll send some follow-up to you to let you know once that's all set. And I hope everybody has a great rest of the night.
Thank you. Good night.
Thank you, Steve.
Thank you.